Welcome to our 111th month in a row of the TMIT National Research Testbed High Performer webinar series. We're delighted to have the subject matter for today being Just Culture, Voices from the Frontline. I'm Charles Denham. I'm chairman of TMIT, and I'll be your host today. And I just want to cover a few housekeeping details with you so that the experience can be optimal. If on slide 3, you'll find some instructions regarding turning your audio up as high as possible in terms of the audio on your computer and the audio on WebEx, so that you can make sure that you have a good experience. If you have a problem, and I'm on slide 4, click on the participants icon and then click on the telephone request phone button, and you'll get a toll dial-in number that'll be a landline that may give you better audio. I'm on slide 5, and so for those of you that aren't on yet, don't have the slides yet, please go to www.safetyleaders.org, and in the upper right-hand quadrant of the landing page, click on Upcoming Events. And when you click on Upcoming Events, you'll see today's webinar. If you click on that, it'll take you to where you can download the slides, but also in future, after about 3 business days, the entire program will be audio recorded so that you can watch it, and we'll be adding other resources and articles and other content that might be of help to you. And you'll be able to land on that page to be able to do so. That landing page looks like slide 6 for those of you that have the slides. And if you go back to this page, and you'll be able to find it in the future by clicking on webinars and meetings, you'll be able to download future articles and other content that our speakers may want to provide for you. And you'll see a picture of David Marx on that page. On slide 7 are our social media addresses for future reference. And then on slide 8, our TMIT purpose statement, and I'll read it very briefly. We will measure our success by how we protect and enrich the lives of families, patients, and caregivers. So we are always wanting to focus on the entire ecosystem with both patients and families, inpatient, outpatient, as well as the caregivers, and all of those and their families who are involved in the care or receiving care. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. And we've found that if we focus on the life-saving things, that a lot of the other adverse events that may not cause life-threatening issues also improve. I won't read our disclosure statement, but and you can read about each one of the individuals. I will be not talking about anything referable to any product, service, or technology. You will be able to read more about the other speakers there. And this program has not been funded in any way, directly or indirectly, by the healthcare industry, product, service, or technologies. Our speakers are David Marx, Sandy Coletta, Alan Forrester, Dan Ford, and I'll be your host. I'll speak a little bit at the outset. But before we get started, for those of you that have joined us for the first time, we always want to have the voice of the patient and family to be able to set our compass on the true north of what we're doing and really get us focused. It's a real pleasure to have Dan Ford, a long-time patient advocate of many years, a senior executive in the healthcare industry in the search area, who now donates his time to multiple activities in patient safety and quality, and has been a terrific champion for things like bringing patients and families into root cause analysis. He is a published author. He was a contributor to the National Quality Forum Safe Practices, patient and family area in each one of the sections of the NQF Safe Practices, and has also served on committees both with government and with patient safety organizations. Finally, every other week he meets with us with a group of patient safety advocates on championing the cause of new areas and keeping the flame alive in areas of patient safety. So, Dan, it's with great pleasure to have you set our course for us today.
Thank you, Chuck. You're very kind, and I once again am honored to participate. And I want to welcome all that are involved today, providers, patients, and family members, and the faculty. This subject is very important to each of us, and we should all learn from this. Just the title alone, Just Culture, suggests there's too often an absence of and a need for a just culture in healthcare. And we understand and wish to change that. In his 2009 book entitled The Price We Pay for Expecting Perfection, David Marx cited a resource. That resource was the children's book, The Little Engine That Could. The little engine willed herself, believed she could conquer the mountain pass by repeating, I think I can, I think I can. And that phrase, as David suggests in his book, is key to causing and to relying on a number of important and related factors that we should experience as we go about our daily work. Appreciate your participating, and let's now dig into this subject. Thank you, Chuck.
Thank you very much, Dan, and that was my favorite book as a little boy, so that's really fun for me to refresh my memory on that David addressed that. So my job now is to very briefly and very rapidly go through in the news update and also our webinar national survey that is really pertinent to Just Culture. However, with this recent active shooter event that occurred yesterday, I've added a little bit of content, and indulge me for an extra few minutes to help champion the cause for the Stop the Bleed program. We have over 300 participants live today. We've had almost 900 participants register for this webinar, so I know many of you will come back. And today, the 15th of January, 2018, for those that watch this in the future, is the day after a terrible shooting in Florida. And there have been 18 school shootings since January 1st. And we have the honor of participating in the Stop the Bleed program, which is an opportunity for all of us as caregivers to become trainers and all of us to become trainees in the ability to reduce the preventable deaths. So on slide 13, I have the reference to that. I'm going to cover in the news, but then also make the pitch to you to consider starting a Stop the Bleed program in your area, and keep it short because David Marx and our other speakers are covering the topic at hand. But on slide 14, the Washington Post published this morning the numbers of the shooting totals since 2000, middle school, elementary school, and high school shooting events. And I think it's really, this slide may help you if you are making the case. And again, that's not the subject matter for today, so I just provide that slide and the reference to that article for you to see how frequent these occurrences are going on. One of our just the North Star, a journalist one time called Don Berwick the North Star of patient safety, which he had been, and he's been a mentor to me and such a blessing to all of us, actually chaired the National Trauma Care System article at the National Academy of Sciences. I draw your attention back to that because it illustrated the critical nature of what we could do in the public if we learned from the military, integrating the military and civilian trauma systems and addressing mainly bleeding in the pre-hospital and the bystander care area. So I draw your attention to that. It's a terrific article. And it helped influence the guidance of our program called the MedTac Training Program, which we've partnered with leaders from MD Anderson, from the Mayo Clinic, from Harvard, from Stanford, from a number of great organizations and many frontline organizations that are doing a great job focusing on the 7 leading causes of death. And the 8th is this bullying or abuse of power that can lead to traumatic events, and that's, I think, fitting for Just Culture. I've covered it on numerous other webinars. I won't cover it today, other than this program addresses and tackles this active shooter issue in addition to cardiac arrest, choking, anaphylaxis, opioid overdose, non-traffic related transportation accidents, and other common accidents, and teaching bystander care. And so we've incorporated into that program the Stop the Bleed program. On slide 18, if you go to bleedingcontrol.org, click on that URL, you'll be able to watch their videos. They're excellent, and this has been sponsored by the American College of Surgeons and the Hartford Consensus groups. On slide 19, I address their videos, and so you can see on the website, and I think they make the fitting statement, the only thing more tragic than a death from bleeding is a death that could have been prevented. And many of our experts are telling us that the deaths in the recent church shooting in Texas, the one yesterday, the ones in Las Vegas that had tourniquets, pressure bandages, and just knowing how to use tourniquets, pressure, and wound packing would have saved a number of lives. and not to be sensationalistic, I won't pick a number, but the numbers are really extraordinary. If you think about what does this really mean, the course is very easy to take. It takes about 2 hours to do. I challenge every caregiver in this audience to consider getting trained by a trauma surgeon or someone in your community to then be able to train others. We've been training fourth graders and above. They can learn how to use pressure, tourniquets, wound packing, a very well thought out program. And you see on slide 20 that the large stop the bleed kits are now being put in airports near AEDs, but we really want to challenge folks to get those in schools and in public buildings. On slide 21, if you want to find someone in your area or a course going on for Stop the Bleed, they have that. I'm an instructor. A number of us have taken the Train the Trainer course so that we can undertake it. And they're free, and they're led by people that really want to help. And the cost of tourniquets and the gauze and the bandages is so little, and they don't perish. So when a kit is put in a school, in a church, even in our hospitals, they have great shelf life, and you can put them where the AEDs are, and they're absolutely critical. The question we ask on slide 22 is, what if an AED and a Stop the Bleed kits were 1 minute away from any victim? We're finding from the latest studies, especially in King County and in Seattle, that the quicker you can get CPR and an AED to someone, the survival rate dramatically goes up. Imagine having a Stop the Bleed kit and AED, and so you can see an image of a fictitious school that we're building a simulator to be able to actually show where the placement could occur. And I think we need to rethink where our AEDs are and put the Stop the Bleed kits within 1 minute of brisk walking distance, so that you could be back to a victim in 2 minutes. Now, that won't work for every school shooting when kids are cowering and hiding, but have them knowing about it is critical. So enough for my pitch there. I just want to leave with you. Stop the Bleed. Training is free. You can give the training for free. The materials are very low cost, and they could save an enormous number of lives, drawing on Don Berwick's great work as the chair with the National Academy of Sciences report. Enough there. Now let's talk about what's popped up in the news. Yesterday, the top 10 hospital C-suite watch list came out, and two or three that might be of interest to you are digital therapeutics, improving adherence for opioid users, how to get in front of stroke by going inside to the heart with the monitors, and what about virtual reality for pediatrics? Others are very interesting. We just highlighted a few there for you. Now, I'm not going to read through this entire slide because we want to get to David Marx and these wonderful speakers, but there's an article in the Pittsburgh Post-Gazette that was a letter to Amazon, and it was very interesting, applying some of the great principles of their very efficient process to, in fact, patient safety. And you see on item 4 there, highlighted in yellow, I highlighted that it doesn't take 17 years to adopt best practices. They've been really good at it. Why not apply this to healthcare? And as you probably have heard, Amazon's getting into healthcare, as are other major organizations. And item 7 was, don't pay for preventable errors or unnecessary treatments. And so you'll find this article interesting. It's not our topic today. I just wanted to highlight it for you if you want to use these slides to be able to tell the story to others. Another issue that popped up on the 6th of February regarding the errors related to texted orders. And as we all know, Michael Cohen has been an enormous contributor to patient safety and quality, and is really giving us an early warning that text messaging regarding medication errors a critical issue. So you might take a look at the ISMP survey report. 70% of respondents concerned regarding autocorrection of texts, and we all know about that as those of us that use text. Another, since last webinar that popped up you might take a look at is the plumbing issue related to superbugs and drug-resistant organizations in the pipes. We found a hospital, and I won't say the state, but a hospital's ventilation system had terrible Pseudomonas all the way through it, with areas of moisture that had not been checked for a while, and could not understand why their infection rate was so high. And so some of these very important areas, the HVAC as well as the plumbing, absolutely critical. Moving on to opioid overdose, which has been a very important topic you as an audience have really been addressing, was the issue of opioid overdose. And this article, very interesting, that most of the deceased from overdoses were not in healthcare, so these are healthcare employees, were caregivers. We're not doctors, but nurses, pharmacy technicians, and shockingly, even chemical dependency counselors. So no one is immune from this. We're going to be covering it again. You as an audience have told us about the critical need for more drug diversion, which we'll cover again, and we covered in our last webinar. And then the next two slides just address the fact that finally Purdue Pharmaceutical has recognized that they may be part of the problem, and they're stopping the marketing of the addictive opioids to doctors. And so those you might use in some of your opioid presentations. That's 30 and 31. One of the issues is the cost to governments. There's an estimate of the cost to Ohio, which is ranked number one right now in terms of opioid overdose deaths for its population, and an article here that may be helpful to you. So now, polling, and I'm almost done, and I'm going to hand things over to David Marx. Last month, we asked you after a drug diversion webinar, do you want more information, more detail? 55% of you gave it a 10, 89% agreed, and 68% or almost 70% strongly agreed. We will come back to you. And David, we may ask you to team up with our drug diversion experts to help us with this issue regarding just culture and how we handle this critical issue that's exploding. The numbers are just every month going up for caregivers. I won't read slide 34 for those of you to go back and read what specific drug diversion topics that you wanted covered. We will cover them in a future webinar. We asked you if you wanted to have speakers who adopted drug diversion programs to speak, and we're seeing 92% of you agreed, and again, 55% gave it a 10, so we will do it. So we will have another webinar with frontline leaders who have adopted programs and what their journey and what their speed bumps were and what things worked and their surprises. Again, I won't cover the detail. Slide 36 talks about the detail that you want regarding that topic. So now, just culture, my introduction to David Marx. We ask you, are you interested in more detail regarding just culture, even though we'd had really covered it very well? 93% agreed, 55% strong, or 35% strongly. There's a typo there, Kyle, if we want to update our slides. The topics that you ask us, and I'll dwell on this just for a minute, let you read it, but you can see that there's some very, very good questions and comments. Some are a little incomplete. We take them right off of the web and try not to fill in unless we know what you're asking for. But you're seeing case studies, addressing behaviors, how can we work with folks in terms of loyalty, and really you're hearing implementation. I think David has done a remarkable job of selling the concept that we need to have this solution, and now our job, I think, is really in helping him take it to scale. So David Marx is both trained as an attorney and an engineer. He's the pioneer of the just culture movement. He's had a unique combination of systems engineering, human factors, and the law, and he's really been, I think, a role model to all of us on how you can take something to scale and do such a fine job of doing so. Spurred by the Institute of Medicine's 1999 report, To Err is Human, and recognizing the need, they started to focus on healthcare. And so for 2 decades, he's been focused on this topic and the design of effective socio-technical systems. Always thinking, he showed me some of his really wonderful work here the last week or so, and I am so impressed by the creativity and thoughtfulness that he's applying to this very challenging area. We asked him if he could bring back some leaders to speak to us and ask him to do that, introduce that topic. And David, thank you, and we're honored to have you again and for you to bring leaders to speak to our audience. David?
Well, Chuck, thank you so much. Again, this is David Marx, and it's an honor to be back here a second time. I'm just going to be, to some extent, the warm-up man for Sandy Coletta, who was the present CEO of Kent Hospital in Rhode Island, and for Alan Forster, who is a physician in charge of quality at the Ottawa Hospital in Ottawa. I just have a couple of slides that I'm going to show just as an introduction to implementation. I didn't talk about that much time on our last session, so let me just take you through a couple of slides here that sort of lay the groundwork, but really Sandy and Alan will really talk about this in detail, and that's really who you want to hear from. Just some framework, though, in terms of just culture implementation. Again, I'm just going to take you through a couple of slides, but there's sort of 10 steps that I just sort of put down for this discussion. So the first one is the first step is really committing to even explore the idea. A lot of people on the call, a lot of people across industry say, I've heard of this notion of just culture. What does it really mean? And this is something where you have to not only believe it in your head, you have to believe it in your heart. And I think the first thing to do is set out a team of scouts to say, let's really learn what just culture is. Let's look at the different models. Let's figure out what really workplace justice and accountability are going to look like for us. The second one is to then do the deeper dive. And I know Alan is going to talk about this, how he did this at the Ottawa Hospital in terms of bringing together a team of executives, and I think he had the top 30 executives go through a 3-day certification course, which is really saying let's learn in depth the details, both the concepts and the methodologies to how to really implement a just culture. And so I think that's the second step, is really saying we got to learn it, we got to understand how it's going to play out. What will this mean in the long run for us as an institution? The third one is commit to implement, and I think it's time, resources, and probably the most extensive one, and I think Alan and Sandy will both talk to this issue of sort of resolve. Are we committed to going down this path? Because this is one that's top-down, it's leadership-driven, and it's one you don't want to get wrong. It takes some commitment, it takes time. Most people will say just culture journey, even if you say it's a 3-year initiative, most people have been through it say, well, it's longer than 3 years. It's a lifelong kind of implementation. We're always trying to sort of live up to the ideals. So it takes some resolve to really pull this off. The next one is benchmark, is know where you start so you can see what the return on investment is. It can be surveying, like here in the States, the Agency for Healthcare Research and Quality Patient Safety Survey. Auditing, are the behaviors what we want, do we want to see behaviors improve, whether it's 2 patient identifiers going into the patient's room, whether it's hand hygiene. Auditing behaviors to know, are the behavioral choices, is the culture of our team and continuously improving as we do this. The next one is reporting. Do we see people raising their hand and reporting not only on others, but on their own behaviors? Do they raise their hand, say, here is a mistake I made, or here's a choice I made that was risky, that I see is risky? Does reporting improve? And then ultimately, a very legitimate measure is outcomes. And those outcomes are patient safety outcomes in terms of reduced medication errors or wrong site surgeries, but it's also outcomes from things like grievances, lower levels of grievances, because we have what for the staff is a more fair and just culture. The next one is scrubbing policies and procedure. I use the word scrub here because they may very well be in alignment, but often they're not. And it's getting the HR policies in alignment, the learning systems in alignment, the reporting systems, how we do investigation. It's getting policies and procedures aligned to align with the tenets of a just culture. The next one is really training. And most organizations would say this is, training a manager is probably a day activity. I'm sure Sandy and Alan will talk about what they did to train managers to get them to understand the concepts, to be able to do this in their daily work as leaders. The next one is very important, and here probably I think the most important one is, and I use the word covenant, but establish the covenant. And the idea is at some level, leadership of an institution has to go out to its employees and make a unilateral promise. This isn't a negotiation with employees. It's a promise on the part of an organization to say, here's how you will be treated when things don't go as planned, whether it's an error, an at-risk, or a reckless choice. It's a promise. And I know Sandy is going to talk about how she pulled that off at Kent Hospital. Training staff, that's 2 hours is sort of probably the sweet spot, but ultimately staff need to understand what it looks like, whether, and particularly the models of human error, at-risk, reckless, controlled error, coached at-risk, sanctioned reckless, do it all independent of outcome. At some level, staff need to understand here's what accountability is going to look like, because everybody wants the right system of accountability. We're all seeking sort of justice. The question is, what does that look like? And staff have to be involved in understanding the model. Feeding the change, some people may say that just culture is inherently unstable because everything we read on the 6 o'clock news is teeing up people to judge. somebody makes a mistake, there's a bad outcome. It's how bad was the outcome and who are we going to punish. So there is a lot of effort required to feed the change and continuously reinforce the behaviors on the leadership managerial side that are in alignment with just culture. And then last, measuring progress is going back and saying, are we making the progress that we want to make? Is this heading in the right direction? So with that, now I just one last slide here, and just I want to sort of put into the mix is, if we look at just culture across industries, we look at it particularly in healthcare, there's really sort of two sort of versions of just culture that you're going to see. And I think both Sandy and Alan are going to talk about, I think, the right side. But there's what I'm going to call just culture light. And what is just culture light? And I might say this in a bit of a pejorative way, but it's the easy version of just culture. It's only about non-punitive reporting. How do we get people to raise their hand? It's only about safety, it's not about all the values as a whole. It's a safety initiative. And I think if you keep it just a safety initiative, you risk failure. It's only post-event. It's what do we do after a patient's been harmed? And when we talk about just culture, it's what do we do to prevent harm in the first place? So sort of a post-event view of just cultures is probably not a good view. It's all about rules. Ultimately it's about values. Are our employees aligning their conduct with the shared values we have? Rules are part of that, but it's more than just rules. It's somewhere in the policy. We have a just culture policy, don't we? It's in there with the rest of the policy. That's just culture light. Is employees gotta have to know it. Managers have to live it. So it is more than just a policy. It's an optional tool. I've heard folks say, well, look, we'll get into peer review, and if we don't like what the algorithm or our tool set tells us, we're just going to do what we want to do. And this goes sort of back to the covenant piece of it. Just culture, I hope, as you listen to Sandy's and Alan's experience, to their testimony to some extent about their journeys in just culture, you'll see it's about accountability. It's about accountability before and after events. It's all conduct, whether it is a breach of privacy, whether it's saying something that's offensive to a patient, or whether it's physical patient harm, patient safety. It's really about all conduct. It's about duty and breach. It's about what obligations we as humans have, and whether we fail to live up those obligations. It's not simply about outcome, because if you look at healthcare, not only do we, history would say we have an overly punitive healthcare system, but we also play no harm, no foul. We turn a blind eye until somebody has gotten hurt. Just culture is not what do we do after somebody's been hurt. It's what do we do to prevent the harm in the first place. And then if harm unfortunately occurs, we do exactly what we would have done had there not been harm. It's all values. It's what are the values we share as an organization? How do we align our behaviors? It's hardwiring it in. It's putting tools in managers' hands. It's saying, look, this is how we want to do business day in and day out here as an institution. I know that's probably an overused word in healthcare, hardwiring it in, but it really is. How do you hardwire this into our culture? And then, again, it's a covenant. It is living to the commitment that you make your employees about how we're going to think about accountability as an institution, how we're going to hold each other accountable to the obligations that our patients and our customers and the community which we serve. So that's it. And hopefully those things, some of those things come out in Sandy and Alan, and if I got it wrong, feel free to call it out. But anyway, so this is the place where I'm gonna turn it over. And Sandy, and I don't know if Chuck, if you were doing the introduction.
Yes, I will.
Doing the introduction. Okay.
And David, fabulous. What a great introduction, and thank you for the implementation steps. That was very helpful, and it's a great setup. So Sandy Coletta has held numerous leadership positions over the last 35 years. She became very widely known by just uttering the simple phrase, "I'm sorry," in 2009 while she served as president and CEO of Kent Hospital. Accountant by training, her interest in human factors and patient safety, and her core belief in doing the right thing and taking the right choice or making the right choice served as the foundation for her transition from finance to operations and executive leadership roles. Sandy, we're so grateful to have a CEO, and you are clearly a Renaissance woman coming from finance and also being an author of a book, The Owl Approach to Storytelling, Lead with Your Life, shows that you've got that left brain and right brain both working. And we're just so honored to have you come and share your story with us. Thank you, and we're very, very grateful.
Well, thank you, Chuck. It's a pleasure to be here and to be able to share my personal experience in implementing just culture in the hospital setting. It was actually the fall of 2009. Events led me to meet with the brother of a patient who had died in the emergency room at Kent Hospital several years prior to my arrival there. We were in the midst of a contentious and very public lawsuit, and I came to understand how our systems had failed Michael Woods the night he died. My meeting with James Woods and the ultimate settlement that received the attention both locally and nationally for my apology it was amazing. To me, it had been a natural and a human response to apologize to a family for what had happened. But it turned out to be that newsworthy event, and particularly for those who had spent their lives advocating for the patient and patient safety. Letters started to arrive on my desk. People sent personal notes, and I got a few books in the mail. One of those books and one of those notes came actually from David Marx. He put a copy of the book Whack-A-Mole in the mail to me with a note. And I would say that was the beginning of the journey that I'm going to share with you today to take our hospital to a full implementation of just culture. All of us come to discover the power of just culture in different ways, and most of us have done the work necessary to understand what just culture is. It's why we have so many people on the call today. But understanding is not enough. This is an approach not just to patient safety, but to how we live our lives, how we make decisions, how we interact with others. To successfully implement a just culture, you must first believe. Your team must believe. And in the next several minutes, I'm going to talk about forms and classes and policies. But those really were just the tools and techniques we used to help leaders move from understanding to belief. I'm going to tell you a little bit about Kent Hospital. You can see the statistics on the slide. It's a good-sized hospital, second largest emergency department in the state of Rhode Island. But the numbers only tell a part of the story. Kent's a community teaching hospital. Most of the employees who work there lived and, in fact, grew up in the communities they served. Generations of family members were amongst the staff. And although it is a large and successful hospital right now, it had struggled at that time, both with perception and reality of performance. Our satisfaction scores were low, quality outcomes average at best. The nurses had voted to bring a union in October of 2008. They had gone through several years of severe financial distress, and as a result of the actions that were necessary to turn that financial problem around, they then were faced with the negative impact on employee satisfaction and the struggle with quality. So it was that environment and that context that really led us to the process of implementing just culture. And just from a very high level, you can see the phases we went through. And I can imagine what many of in the audience are looking at and saying, my God, 2 years from the moment of awareness to implementation? Then another full year before we were comfortable enough to actually boast publicly about what we had accomplished. Can it be done faster? David just mentioned the time frame. I think not. In fact, I think as we go through this, you'll understand why the time is so very necessary to get this done right. So how exactly do we go from the president of the hospital reading a book along with all the books that we all read constantly to actually implementing? You see, when I read Whack-A-Mole, what struck me is that I think I finally found that missing piece. You see, we had done all the things that we know we're supposed to do. We had implemented a near-miss reporting system. I had a patient safety officer dedicated full-time. We were holding safety rounds. But we had built our safety culture without a solid foundation. Just culture was that missing piece. It was and is the foundation. It's not just a buzzword, but it's a real, tangible approach to how we do our work and how you can actually bring accountability to life. So one of the pieces, and David, I'm sorry about this part, but we didn't hire consultants. We decided to do that initial work ourselves. So we formed an internal work group. One of the pieces that's really important is I, as CEO, led that work group, and I led it through the entire duration. We met at least on a weekly basis for the full 3 years. The members of that work group included all levels of management and a cross-section of disciplines. Very early in the journey, we came to understand Just Culture not just as patient safety initiative, but as the way we were going to lead and manage our entire organization. We had human resources on that committee from day one, and not just one person representing it, but 3 seats on the committee. The executive, the vice president of human resources was there, the labor relations director was there, and the employee relations manager. Important to know, this journey turns the HR world upside down, and their involvement from the onset was critical to our success. I would say for the first 6 months or so, that group did nothing but focus on its own learning and understanding. We moved through each one of the duties and behaviors sequentially in our meeting. First, we used training materials, and then eventually we evolved to using our own cases. But what we did was we would read about the subject matter, we would present case studies, we would debate, we'd cycle through it. I will tell you, we argued a lot, but we kept going because this was how we as a committee became comfortable with our understanding. But what's most important is that understanding moves to belief. And how do you know when you're getting there? What I've witnessed in that work group week after week is that eventually what started to happen is rather than the members fighting for what the outcome was and what's the punishment going to be, the questions and the debate started to go from, is this a duty to follow a procedural rule, or is it a duty to produce an outcome? How does the algorithm work here? Is this a at-risk behavior, or was it reckless? We began to look at and discuss the cases in the context of the duties and the behavioral choices. It was at that point that we were comfortable that we as a subgroup, as our design committee, were starting to get our heads around the belief and the principles, and we could then start moving out into the organization. The cascading of this understanding process is key. We recognized that we're talking about a fundamental shift in thought process here. It's not just we have to have a handful of champions or change agents, but we need to shift the thinking of entire levels of the organization to support this process. Those individuals then became the support for the next. We used the same technique as we had done in the work group with reading. I must admit, we distributed a whole heck of a lot of copies of Whack-A-Mole, case studies, and debate. Every management team meeting began with an overview of a duty or a behavior and a case for discussion. Our medical executive committee did exactly the same process with each of their meetings. We took our board through the same learning experience, but with the board, we took an extra step. I actually had them vote. You see, what a board of directors needs to understand is that there will come a day when an event will occur and there will be no punishment. And as representatives of the community, they had to be prepared for the feedback and the pressure they would get. They also needed to understand that there would come a time when there would be a discipline or a punishment when there had been no bad outcome. And they would be getting calls as to why did they do that? Why did they discipline this employee when nothing bad happened? From a board perspective, it was critical that they understood and that they believed that what we were doing was the right thing. So we went through that process of getting there over in verbal commitment. I actually made each of them express their yes vote verbally out loud in front of one another. It wasn't just a group vote raising their hands. They each had to speak it. So now if we do truly believe, then there are a few things we have to do. Now, I know you have them. We had them. Every organization does. Those policies that were written years ago that are no longer applicable or enforced. Worse yet, they're enforced inconsistently. But if you believe in the duty to follow a procedural rule, then you must also believe in those rules. Just one example, we had a dress code, as most organizations do, and our dress code prohibited denim. Funny thing was, though, I wore denim skirts to work routinely. So the question became, do we change the policy or do we hold the CEO accountable? Because if you believe, you must. We have employees who have the duty to produce an outcome. Do they know what we expect? If we believe, they will. Do we believe that performance is based on the quality of behavioral choices? If so, then our HR systems have to reflect that as well. Do we hold everyone accountable? Physicians and cooks, nurses, managers, frontline and senior executives? We have to ensure that we have all of that in place. Consistency. So what did we do? We began our implementation by looking at 100% of the hospital-wide policies, not just the performance appraisal policy, not just the discipline policy, but every single hospital-wide policy the implementation team worked their ways through. We used focus groups. We went out to the managers, whatever the appropriate audience was, to make sure that we had a policy that we as a leadership team were consciously agreeing to hold ourselves and our staff accountable to. This took over a year of that process time to get through, and I think you can imagine the amount of work that goes into that kind of assessment, whether it was dress code, smoking, time and attendance, every aspect of the organization. We then later in the process directed each of our department leaders to do the same with their departmental policies. 6 months prior to the planned rollout to employees, when we were getting ready to bring it out to them, we had every manager complete the online training modules in event investigation and in coaching and counseling. We had redesigned the coaching and counseling tools and thrown away all of our disciplinary forms that we had previously. But it wasn't about just filling out a form. The managers really needed to have the skill to provide that. They also need to understand how to investigate an event. They could no longer stop at the first piece of information they get. They had to continue to ask why and get down to the root cause when an event occurred so they could know how to apply the algorithm. This was a critical component of the training. So it wasn't just about the concepts of just culture. They had done that already through the management meetings, the reading, and some online training, but they had to have these extra skills to be successful in sustaining our transition. 3 months prior to our employee launch, we actually held an in-person session. David was brought in to speak then. And in that session, we included not only all of our management at all levels, but we also brought in our physician leadership and our union leadership. One of the critical success factors for us was the engagement of the union. Our union contracts had languages added to them to reflect their commitment to just culture, and they were with us all the way through the implementation process. There are a number of key critical steps to the employee launch, but most importantly, and this is a really important thing to remember as leaders, is that the day that you launch this to your employees, it is the first day of the employees really beginning that process of understanding. As a leadership team, we've been spending years really getting our heads around this. But as the employees get brought in, we have to accept the fact that they are going to go through their own process. So the first step for them was to begin that awareness component. So about 3 months prior, we started with newsletters, did the commitment video, which I did, that went through the whole concept and the teaching the different aspects. We held employee meetings and, again, shared a lot of case studies. Here's an example of what a at-risk behavior might be. Here's an example of the different duties. A month prior to the launch, we mailed to everyone's home a packet that had, again, a lot of the reference, the language, the definitions, the new coaching and counseling tools, all the information that would be really more of a reference source for them as they went through this journey. And they went through the process of beginning to understand. But to get them to believe, to have your employees really believe, this is, it's what we always hear about in terms of walking the talk. So once you have implemented Just Culture, this is the way we're going to manage events that don't go as planned. Now you're in a critical period of time where you're confident and you're getting ready to interact with your employees, and they have to see that you are doing what it is you said you were going to do. This is really more critical than anything else. So we shared information. As we had cases that we managed through the algorithm and through the process, we actually blinded those case studies and began to share them with our employees through our daily newsletters. They could see that this is how this occurred for this employee, blinded employee, but this is how it would occur. If a manager ended up, as they went through the algorithm, with the conclusion that it was in a situation needing a punitive action, we had that manager come to the Just Culture Committee, not as a critique more, but as a reference, as a source, as someone to help them make sure that they were managing it appropriately. So the Just Culture Committee would hear the facts, the manager would present them, either send them back to do a further investigation, ask them questions, and then support them as they went forward if it was still going to be a punitive action. And sometimes symbolism, I think, is really important. So at the beginning of the implementation, we held a session where all of the disciplinary forms that we had in the organization, we had every manager empty their drawers and their file cabinets. And you can't obviously burn them in a bonfire, so we did the next best thing was to put up a shredding box, and every one of those forms went into the shredder, and we took pictures and we celebrated that we had left the world of the old punish first kind of environment, and we're moving into a new approach and new way of doing things. But how do you get this to stick? I actually left my role as president of Kent Hospital in 2014. And there were elements that I know that we put in when we went through the implementation and the years followed that have allowed it to continue to be a strong aspect of what Kent Hospital is. As I mentioned, the union contract, that contract has been renewed several times, and the language relative to just culture and the union support of it remains in that contract. Every new employee still sees that commitment video that I filmed years ago as they enter their new position. Every manager is still taking the same training when they're hired into the organization. As generally they don't come in with this knowledge, so they go through those same modules that the managers had to do at our original implementation. My successor in the role of president actually was the chief medical officer when we did the implementation. His name today is signed on the current version of the Just Culture policy. And I would tell you it's quite a statement, because if you remember back when I told you we argued a lot in some of those sessions, I would say he was one of the strongest voices opposed to implementing Just Culture. And today he is one of the strongest proponents. So you really have to be focused on implementing, and David used the term hardwiring, and as much as that is somewhat of a buzz term, it's very true. If you put the components into the system that allow it to remain, that's how you can leave the organization and be confident that they're continuing on the path that was established. So we talked about this segment as a CEO perspective. So I have a couple of high-level observations from the experience that I had as a CEO doing this. First and foremost is, and I mentioned this already, this is not a patient safety strategy. It impacts the entire organization, every department, every piece of their performance. So I think when you come out of the box, you have to understand that we can't segment. I couldn't have an organization that would follow Just Culture for a safety event, but that it would still use the same old-fashioned disciplinary approach for somebody who punched in late 2 times in a month. So that whole hospital, whole organization perspective is critical. As a CEO, it was important for me to understand, and honestly, it took a little bit of time to get this and get my head around it, is the duty to avoid causing unjustifiable risk or harm is not always as clear as it was, as I thought it was in the beginning, because it's not always about a personal injury or death. It's about all aspects of organizational risk. It might be reputational risk. There's a lot of organizations out there today that are dealing with reputational risk. It could be strategic risk. this duty applies to one patient or applies to hundreds of patients. I touched on this when I talked about the board effect. When you make the decision to implement just culture, you are making a decision to do something that is different from what society believes to be right and true. As the leader, you must be willing to be the one who will stand in defense of your employees when others want to blame. We knew that we would face situations where the State Board of Licensure of nurses or physicians or pharmacy would want to take a punitive action against an employee that we felt had only had a human error or a at-risk behavior that needed coaching. We couldn't change the way those societies worked and those disciplinary boards worked, but we agreed that we would be there to stand and speak in their defense. That is what it means to be a leader when you're implementing just culture. And we also have to be ready to stand firm when people think we're overreacting. I did get my share of phone calls on occasion for actions that we took that others could not get their head around. They did not understand why it deserves such a strong response. And if as a leader you're not willing to stand firm for your employees, then you must not embark upon this journey. Your organization needs you to be there for them. This phrase is a quote I selected, and I think it's really important that if you wait until everyone says it's fine and it's the right thing to do, then I think you're late. Those of you who are interested in just culture and want to join the movement now and get started, it's a long journey, but you've got to do it, even if others aren't willing to do the work that needs to be done. I must admit, for me, just culture is how I live. It's the way I approach everything in my life. It will likely be that for many of your employees. For some, though, it will not be. They will not be comfortable with the conflict with society, the conflict with what the external world thinks. They may not be happy in your organization. We hear this often in any kind of change initiative. But remember, we as leaders have accepted a duty to produce an outcome, to bring just culture to our organizations. And just as we don't expect 100% adherence to every policy, we don't expect people to be perfect, we can't expect that we're going to have 100% support. But we still have to do it. We still have to be willing to be the leaders and make this happen for our organizations. So I thank you for giving us the opportunity to share our experience and for being interested in doing this. And then I will turn it back over to Dr. Dennis.
Well, I just have to tell you that I am just blown away by your leadership, and I have so many questions because it's just a remarkable story, a remarkable journey. Thank you for telling the story, and we can't wait to hear more about these challenges, because this is, when you're in your heart, when you're hearing somebody tell the story about how to do it right, I kind of feel like I heard that from you personally. I don't know about the rest of the audience, but I am so impressed, and thank you so much for sharing your story and how fundamental it was in the story about your lead medical person. There's nothing better than having a skeptic become a champion, because you know that the content is right. So thank you so much. It was many questions, but spectacular presentation and so appropriate. And I wish we could have more CEOs listen to you. So my honor now is to introduce Alan Forrester. He is the Vice President and Quality Performance and Population Health at the Ottawa Hospital, Vice Chair of Quality and Clinical Services, Department of Medicine. He's on the Faculty of Medicine, a professor. He's a general internist, and his research focuses on patient safety and quality improvement. He's performed seminal work in evaluating the incidence of adverse events following discharge from hospital, which is so critical. And we just see a real tip of the iceberg in what we see in the hospital. So we really, really know that that is such an important area. He has over 160 publications in peer-reviewed journals, and has been a great contributor in many ways, recognized by numerous awards, and you'll be able to read his bio on our website. But without further ado, we'd like to have him tell his story. Alan, thank you again, and we're honored to have you also speaking with us, and we're grateful for David reaching out to you and having you join us today.
Well, thank you so much for having me, and it's such an honor to be on the panel with everyone. That was such a, as you mentioned, that presentation by Sandy was very, very inspiring. So hopefully I can do this topic justice in the same way she has. As was mentioned, I'm a general internist, and I've always been very focused on patient safety. And I have to say, I've been motivated by trying to improve the patient safety just on a personal level since I was a trainee. But I have to say, I did research work, as was mentioned, but really when I met David Marx about three years ago, and we started bringing the just culture to the Ottawa Hospital, I have to say I really found that it was a massive benefit, and I wish we had done that work earlier. So I'm just going to talk about in our situation a little bit about what the Ottawa Hospital is, and what motivated us to get to try and implement the just culture, and then finally how we did that, and then lastly some of the impacts that we've been observing. So this is the Ottawa Hospital's strategy map, and we're an academic health science center. We have 4 major sites where we provide care. We have about 19 different facilities across our region that we're responsible for. We have about 12,000 employees, 2,000 physicians, and 2,000 learners who come through on a regular basis. And we're all striving really towards our vision, which is to provide each patient with the world-class care, exceptional service, and compassion that we would want for our loved ones. And you'll see below the goal that we have. This is an old strategy that we had. This was changed last year, and I'll say right now that it was changed because of the just culture. But I think you'll note that that's the IHI's triple aim that we have as our strategy around better patient experience, better quality at less cost, and healthier populations. And you'll see as I go through that the just culture has actually fundamentally changed our overall strategy, and I'll get to how we changed it at the end of the presentation. I have to say though that we've been working on this piece to provide each patient with world-class care, exceptional service, and compassion that we would want for our loved ones. Really, that has been driven by our hospital CEO, who will not rest, I think, until that vision is held. He's a long-standing CEO. He's been with us since 2001, which, for a hospital CEO, at a teaching hospital, is quite a long tenure. And he's always been focused on this, and I have to say he's really inspired our whole workforce to be driving towards this. Obviously, safety is a big part of that vision. And we have been very focused on safety since early 2000s, and but I would just argue, and we've made some strong advances. But I have to say that as someone who's monitoring performance within the system and monitoring people within the system, we really weren't making the strides that we wanted to. However, at least externally, we were viewed as a leader in patient safety. In 2015, we had a bit of a wake-up call, not because of a patient safety event, but actually because of a staff safety event. And it wasn't actually one event, but what it was that our Ministry of Labor in the province had decided that healthcare worker safety was a key priority, and the Ministry of Labor was going to take an approach whereby they would make examples of organizations. And so they came in with a strong audit process and actually sent in people into our hospital because we are the biggest hospital in Ontario. So they felt we'll go to where the biggest hospital is. And really what the auditor found was that there was very significant concerns about staff safety, to the point that they were threatening significant fines. And in their report, they commented that we are recognized as being a safe organization from the patient point of view, and that we should put as much emphasis on our patients or on our staff as patients, and we would be much better off. And really, that is what led us to the Just Culture. This particular report from the Ministry of Labor is what led us to really go after this. And I have to say, being in patient safety research, I knew about Just Culture and I knew about David Marx, but it really prompted a more in-depth look, and actually prompted us to bring David up to Ottawa to give a talk to our senior team. So in his presentation, where he talked about exploring the idea, the way we did that was we have an annual patient safety day, and we changed that to a patient and staff safety day, and we asked David to be the keynote speaker, and also had him speak to our entire executive team. And that initial exploration led to us moving towards what we're trying to achieve. We know, on the left of the screen, we know that patients and staff have considerable risk of injury in our facility. And we know that because we audit, and because of what's known outside in the literature. And so if you look at the numbers and the stats, it's as most people on this call know, it's extraordinarily high. 1 in 10 patients are experiencing some form of injury during care, and more than one person is experiencing an injury. More than one person are experiencing injuries in our institution every day. So our goal really through this is to improve those outcome rates, make it safer for patients and safer for staff. And also through this exercise, we feel that there's a huge benefit to improving engagement of staff and physicians. As I said, we're very focused on this goal of providing world-class care, compassion, service excellence to our patients, and we will only do that if we have full engagement of our staff. And we feel that we felt when we started this journey is that part of the lack of engagement that we had was explained by the lack of consistent and reliable systems for ensuring justice. So what are we trying to change to? We want to be in this place where we is putting quotes, is it's people, it's all people at the hospital are 100% confident in our collective ability to learn from failures, so that our system and behavioral choices continually improve, that we are collectively and individually accountable for behavior and our system, and we strive for optimal safety for our staff and patients, and we are aware of and monitor major threats to safety, and we're continually vigilant to the possibility of new threats. And so, as I said, we didn't feel we were there when we started this. And I would say when we started this, there was evidence that this culture was actually not there. We did definitely see evidence of the outcome bias. We did definitely see evidence of the no harm, no foul. And really that is the underlying shift that people we're trying to push people away from. So our programmatic approach is the Just Culture. Just for people who don't know, haven't read about the Just Culture, defined it's a system of justice, investigatory and disciplinary action that reflects what we know of socio-technical system design, human free will, and our inescapable human fallibility. Part of our evidence that we needed to change our culture was that when we mention the word investigation, that automatically gets people nervous that there's something bad going to happen to them. And I think that is actually one of the symbols that, for me, in my mind, that we just do not have an appropriate system of justice in our institution. I'll just say that unpacking this definition requires one to really work through our capabilities within the institution. And I would say that, the investigation process is critical and needs to be pushed down through the organization so that it can happen at all levels. But because ultimately the investigation process is what allows you to make the decisions about the accountability, about the accountability for behavior and the accountability for the design of the system. Again, for folks, just as a refresh, the model is based on the issues around the behaviors being human error, at-risk behavior, or reckless behavior, and this recognition that the at-risk behavior, this failure to see risk, or the mistaken belief that the risk is justified, is really the key piece. And this is where most of our effort is being focused on. I'll just quickly go now through our rollout because I think there's a lot of similarities to what Sandy mentioned, but I think it does also help to outline what David Marx identified as the key critical path. So as was mentioned, we kicked this off when we presented, as I mentioned, when we did the exploring the idea, we'd brought in David in to speak to our leadership team. That led to us then performing a certification course here in Ottawa. And we actually trained about 50 of our top leaders at that session. And that was our first push at this to sort of help us say, do we really want it? And that was a command performance from our CEO, where, Dr. Titz basically said, you have to come to this. And so at this meeting was the entire executive team, which includes our vice presidents, as well as our entire leadership of our medical staff, so our chief of staff and department heads. And then we also brought some core directors from IT, from the human resources team leadership, and the quality leadership. So that was the kickoff, and that was really, at the end of that session, is we basically wanted to make the decision, should we carry on with this? And I would just say, after that certification program, there was universal agreement that this was the right way to go. And there was a decision to move forward with it. We then, had to go through a process of defining how to move forward and how we would make it happen. And the next sort of major milestone for us was to get an internal group, and again, analogous to Sandy, we decided we were going to do this largely on our own, and we trained up a team of leaders who would then be the trainers for the rest of the institution. Within 6 months, we had the managers fully trained. And managers also included our physician leadership. So we have, we actually have 47 divisions within our medical structure. So we, at the same time we were training our managers, we put our physician leaders through that in two waves. The first wave going in September 2016, and the second wave going in January of the following year. We then, also discussed was the idea of kind of feeding the change, and by this point we had some turnover in our VPs and directors, so we refreshed some of that certification training, and we also identified the need that the training of the just culture algorithms and approach really would not be beneficial unless we could also start thinking about some of the downstream impacts, one of which is to help people recognize at-risk behavior. And so we started flowing our managers through training to help them with coaching at-risk behavior. In parallel to this work, we had to perform some system enhancements. We made some modifications in our safety learning system, which previously had been called the patient safety learning system, but consistent with this shift to our to staff safety, we changed the word to just safety learning system. We developed an investigation training approach for our management team and special quality leads within each clinical area. And that has been implemented. And we did the scrubbing of policies, as was mentioned. I have to say some of this has been done in parallel. We recognize that we have lots of policies. And so we hit on the key ones initially, but have gradually worked on certain policies as time has gone by. I think the most important part of the work that we've been doing is the stakeholder engagement. Our board, this was a topic at a board retreat. We didn't go through a formal process of a vote, but we did certainly engage them and get their support for the movement forward. This has been part of our corporate work plan and seen as a key strategy for our future success. We provide regular reports to our board because of it being attached to our strategy. Another key group was with unions. We have a highly unionized work environment with 90% of our employees being unionized, and so the ability to get them on side was critical. And we brought them in very early on, and the message from the union leadership was, we really like the idea, but we don't believe you'll follow through. And if you can, we'll be very supportive. I'll speak a little bit about how that's turned around since we've pushed this in. We also have Leadership Development Institute presentations, which we bring all our management team, and we provide regular feedbacks there. And then lastly, we've had some discussions with key groups externally, including our medical school, our malpractice and insurance group, which is called the CMPA, as well as our hospital association, all of whom have been very supportive and have really actually engaged us to move forward. So I think, have we had impact? Well, here is our new corporate strategy, and I don't know if people can recall when I showed the first one and know and be able to spot the difference. The key difference is now that we've added this fourth aim, the quadruple aim, which is to have a better staff experience. And I have to say that our Just culture was a key movement towards making sure that our staff experience is stronger and better, and it's a key enabler for that. I strongly believe that, as I said, that the staff are fully engaged. If staff are fully engaged and supported towards the mission, and provided the pathway and consistent management approaches, that they will have better experience in our institution. I think it's worth, though, looking at some measures that are a little bit more tangible. Here's our hospital standardized mortality ratio, and you'll see we've had some consistent improvements. This is just one measure just from the outside that says that we're doing okay. It doesn't necessarily imply that the Just culture is to blame, can be defined as the causative factor for this. But you'll see that we've had consistent improvement both against ourselves, but also in comparison to our peer hospitals across the country. We're one of the top performing hospitals for a commonly used patient safety measure. We've seen some other impacts. We've certainly seen through our safety learning system that we have an increase in our voluntary reports. We have an increased number of events that are being processed in a timely way, being investigated in a timely way. We've had a large reduction in our grievances. This is grievances in our nursing union, but we've also had similar reduction in grievances in our support staff union, which is actually 40% reduction in those grievances. And I think, giving the tools to managers to be more consistent in their application of discipline, which are backed up by proper investigations, I think is probably the main driver for this. We've developed very strong relationship with our union leadership, in particular with our nursing union. The nursing union has actually highlighted us and has made us an example for the work we're doing. And I can tell you that during times when there's a difficult economic times, those strong relationships with your union leadership is critically important. The strong buy-in from clinical leaders is also very evident. When we have event discussions and we're investigating events, the support and contributions from our clinical leaders has greatly improved, and that has really led to our ability to understand the events that we need to focus on and really help us learn. I think we also, to a certain extent, have learned what we need to work on, and where we have to keep driving some improvements. Fundamentally, the task of coaching is still something that is, a task that probably is never perfected, but one that you can definitely learn skills to do. And, having management gain skills in that is an ongoing improvement opportunity. Our investigation approach, making it more consistent, making it more user-friendly, is something that actually has been identified. When we're in a big institution the size of ours, driving that through is really critical. Our system design skills, one of the things that this has prompted us to do is to hire some human factors experts and some engineers into our quality department, which is quite a cultural shift for an organization that typically relies on its healthcare professionals to do the improvement work. And then finally, I think our proactive learning system and how we incorporate our learnings from our incidents into what we know already are the risks facing our patient, and how we then plan out what work we do to try and mitigate those risks. We see some great opportunities in that area. I think moving forward, our next piece is really to provide some ongoing measures of outcomes and processes that we would be tracking moving forward, and these are the ones that we're putting forward as the measures of success. So, just in summary, we've had good success. I think, as has been mentioned, it is a journey. I see this as being something that, we're about 3 years into it now, and it is something that we're committed to. There are always countervailing pressures. We have budget issues. We have other priorities, such as, implementation of electronic health records or facility issues that we're always having to pay attention to. But ultimately, all of that work has to be grounded on a system by which, staff feel confident that when they make a mistake or when they see unsafe behavior, that they can raise or they see broken things that are not working, they can put up their hand and say, look, this needs to be addressed. We need to work on this. And unless you have that strong foundation, I'm very certain that we will never get the safety that we desire. Thanks again for having me. I think this is a really great session, and I hope I provided the information that people were looking for.
Well, many thanks. What another spectacular presentation, and really giving us ample detail, and we just compliment you as well, and just terrific leadership from what you've done there. What I want to do is open things up to have some cross-reaction. Since we had 3 speakers today, we didn't add additional reactors other than Dan Ford. And so I think, first off, what I'm going to do is remind the audience that we're going to put up our survey, the survey questions that we have, and we survey you frequently. And remember to scroll down to answer all the survey questions, because we use those questions to drive our agenda. And I'm going to go through those very, very quickly first, so that everybody knows what we're asking about. And then I'm going to ask David Marx to comment on the 2 wonderful speakers that he had, then go to Dan Ford, and then have our speakers comment. And then we'll open things up for Q&A. So, but the first survey question is, since we started with this terrible event that occurred yesterday and the Stop the Bleed program, the question is, would you like more detail or a separate webinar or a webinar on Stop the Bleed, how to implement it, and have some of the leaders of the program, national leaders, help you? The second question is, what information would you like about the Stop the Bleed program, and how one can be launched through your organization in your community, and what's going on in your community? The second survey question is, would you like to have more detail on Just Culture case studies? These have both been just incredibly informative and really have brought life to the concepts and the terrific work of David Marx. So what I'd like to do is ask you, would you like more, or would you like Just Culture case studies? And if you do, or even if you don't, whatever information on Just Culture, the free text entry question is the second question about Just Culture, and we'd like to survey you, and David and I and the other speakers will review those. The third one is, I'm interested in what to do after a patient safety incident. It might be a patient safety accident where a patient is harmed, a caregiver is harmed, and the cycle that we see at the name, blame, shame cycle, and care of the caregiver might be an example, but not limited to that. But specifically, what to do if we have a wrong site surgery, if we have some kind of an event that is clearly an incident that is a system failure, a communication failure, or an individual caregiver or multiple caregivers failures to in both omission and commission, which we've learned with the Gene Huddleston, that only 20% of what we see in patient safety data is really our errors of commission, and 80% are under the waterline are the errors of omission. And then what specific information, the free text entry question is, what information would you like to have? And then the final question is regarding all-cause insider and outsider threats. We're focused on this all-cause threats to the people, the patients and your caregivers and property that could impact patient and caregiver safety. And if you have any areas that just aren't being addressed in patient safety on insider and outsider threats that could include cybersecurity and other areas, we'd like to know about those. So I just wanted to review those quickly. David Marx, could you please comment on both of our wonderful speakers and what you'd like to add, or what you think might be important to underscore before we ask Dan to react?
Yeah, thank you so much, Chuck. And Sandy, Colette, and Alan Forster, wonderful presentations. I just knew they would be, and very, very inspirational about how you have implemented Just Culture.
Let's go to Dan, and we'll come back to David when his line's better. Dan?
Yes, Chuck, thank you very much. I have one question with a little bit of a backdrop to start. The question is, how do the speakers see Just Culture and the root cause analysis blending together? It seems to me it's a hand and glove, either or both. Reason for the question is, the reason I'm an advocate, the reason that I'm on the call today is going back some years. My wife experienced permanent brain damage, permanent short-term memory loss as a result of an overdose on morphine when she went in for hysterectomy. And there were a number of other errors that happened after that. I asked questions about what happened. I tried to get involved in what was not called root cause analysis at the time. I don't know what it was called, but I was just basically told to stay out. asked a few questions that were answered, but there wasn't anything that I would call a discussion. For 14 years now, I have been planting seed nationally this very hot potato about inviting. Keyword is invite. It's not for everybody, nor is everybody going to accept the invitation, but to invite the patient and perhaps a family member, depending on the situation on the event, to participate as an active member in all 3 steps of the root cause analysis. Not everybody uses 3 steps these days, but the investigation, discussion, and the game plan for the future. I strongly feel there are benefits to inviting the patient family, the learning, the healing. It's good for the business case, and I just simply think it's the right thing to do, that kind of transparency and openness.
Great. So, Sandy, while we're waiting for David to jump back on, Sandy, do you want to react to that? And then Alan?
Yeah, I agree. They are completely tied together. I think when you go through the process of really focusing on event investigation, you make the entire organization more comfortable with the idea that they really have to do the work necessary. While we never actually literally invited a patient into root cause, I can say there are many cases where I can remember sitting with a patient or patient's family with their medical record wide open on my CMO's lap and walking through with them what happened and asking questions. So I would say that we often would interview or meet with and get that information for their perspective. I think that what you're advocating for is a wonderful improvement to the way we conducted those investigations. But I think step one is for when the organization's in a trust culture mindset and open to really finding what happened, they have to talk to the patient. They have to be willing to hear that voice.
Great. Alan?
Yeah, I would echo what Sandy just mentioned. I find that the investigation of what I'll call the less contentious, perhaps, or less, when you're investigating events where there is no significant harm to the patient or to the staff, it actually, you learn how to do the investigation, and you really push down the anxiety that the investigation makes or creates. And by just walking through the same process every single time, regardless of the severity of the outcome, it really just makes it much more likely that staff will come in feeling supported when the unfortunate, more severe outcomes start to happen.
Right. Is David back on?
Yes, I am, Chuck. Can you hear me well?
Yeah. Do you want to react to Dan's thought briefly regarding bringing families into the root cause analysis, and then also thoughts that you have to reinforce or underscore what both Sandy and Alan said? And then Sandy, I've got a couple questions for you, and we'll ask our audience to go to the Q&A window in the lower right-hand screen of their view, and if they have questions, that I'll voice them for both you and Alan. But go ahead, David, react to the root cause analysis, patients and families, and then what would you like to underscore that our two great speakers covered?
Yeah, so the first one, I think it is a great thing to bring families into the root cause analysis. I understand the trepidation that organizations have. My wife says nothing about me without me is her sort of motto about healthcare, whether that's going along the way or even after the event has occurred. And I think there are struggles to get there, but I think it's absolutely the right place to get to. And there are hospitals out here who have, in the U.S., who have done a great job of bringing families into that process. The thing I want to add about the presentations is I said in my initially opening statement, I said this isn't a safety initiative, and I wanted to speak just for a moment about Alan's comments. As a chief safety officer, he said the burning platform was employee safety, and but the testimony to what happened at the Ottawa Hospital is, if you walk up to Jack Kitts, the CEO, or if you walk up to Renee Lebert, the Executive Vice President, Chief Human Resources Officer, you'll have the same just culture discussion with the two of them you'll have with Alan. It's something that Alan hasn't done in isolation. It's really across the board, and I think that's the message that is important to take from Sandy and Alan is to do this. Everybody has to be involved. The labor unions, bringing the regulator in, and really knowing that this is a long-term journey. And I think both of them, Sandy and Alan, spoke to that issue of this requires a lot of resolve, and that's probably the right word. It requires a lot of resolve to stand up and say we're not going to discipline this employee, or here's the actions we're going to take. So I think the credit to both of them for having the resolve to actually implement this and push it down the road, ultimately to be a better service to the customers and their own staff. So thank you so much for both of you for presenting.
Great, and I'll go to Sandy right now, and I'm looking at some of the Q&A questions, and so I'm going to, Sandy, two things. One is anything you'd like to reinforce, but the second is Andre Niedermeyer asks, I'd like to ask Sandy, with regard to the shift in just culture, were you able to measure with data changes in the way you measure outcomes? Was there a change in outcomes of harm? And then I'll come back with another question regarding incorporating just culture with the physicians in peer review, and did the peer review use the just culture algorithm? And I'll come back to Alan right after you, Sandy. Go ahead.
All right. Well, I'll answer the last one first. Is yes, in fact, they did. The medical staff was trained in the algorithm and started to use it in the peer review process. So that was a yes. In terms of the measurement of the outcomes, the only, we saw improvement in a lot of our quality metrics, which I can't really correlate. The one area where I could see actual correlation is in our employee survey. We had a number of questions relative to favoritism, inconsistent application of policy, et cetera, and we did see dramatic improvement in those scores. So those are the ones that I would say we most clearly correlate. There were a lot of things going on, and we did not do a good job, as Ottawa did, of setting the metrics in advance that we would track to see the success. So in terms of a lesson learned, people should do that. And I think if there's anything else that, I wanted to highlight or didn't stress as much is in the peer-to-peer coaching component. At-risk behaviors, we're blind to them as leaders, most of them. Because, the other employees see them, nothing happens, we don't know about them. If they don't get reported, we don't experience and know what to do about them. So peers coaching one another when they see an at-risk behavior is critical, and that training is also important to do. We didn't start doing it till a few years after implementation. People should be doing that right at the start.
Okay, Sandy, one last question, then I'll go to Alan, and then we'll have Dan close. But Sandy, what's your advice to those of the audience to try to get their CEOs and their board involved in the process? Any advice on having them pitch the idea to get into to fully employ the just culture?
I suppose I could just send them a book. I think that it's a difficult thing to do, but it really is, again, it's the same process about the understanding. I think you've got to find somebody within the organization that they have a strong relationship with and just start. One of the things I did was a book club. Share the book, do the book club, create some momentum so that it gets on the radar. If people are talking about and interested in something, if you can get your HR person to be an advocate with the CEO, that's another strong positive. It's sometimes if the CEO isn't there themselves, getting someone that they listen to and rely upon to say, look, maybe you should think about this, learn about it, read about it, let's talk about it. That would be a very strong voice to get influenced by.
Thank you very much, Sandy. Alan, your comments and your advice on adoption.
Yeah, I have to say I didn't mention during my presentation the coalition that we had guiding this, and the leadership of that coalition. Dr. Kitts, our CEO, is obviously the champion, but myself and our VP of Human Resources really partnered on this as a dyad to move this forward, and just as Sandy has said, this is really a human resources issue, and having the alignment of the professional staff and the human resources department is really critical. I find that there's a lot of coded ways of doing things within professional groups, and although I'm a physician, I can be blinded to some of that, and so to have our HR team fully behind this and actually the ones really driving much of the process I think is critically important.
Thank you so much. And we have to be respectful to our audience who always want to finish on time, and also for our CME. I just am so grateful, David, to you for bringing such great speakers. We could go on for another hour because they've just done such a great job, and there's so much to learn. But what we'll do is close, and we always give the voice of the patient the last word. So, Dan, God bless you for doing that for us, and would you please close us? And if the speakers could stay on just for an extra minute so we could do a process improvement loop, it would be great. Dan?
Yes, thank you, Chuck. I just want to highlight the fact that I think each of you leads with your head and your heart. And I think that I would put the heart just as much along with the bottom line. It's clear in this program, given what I've known about it for a number of years, as well as the speakers today, that you all do that. So I commend you. And thank everybody for listening and for participating.
And so with that, we'll close our 111th webinar, 111 months in a row. Thank you so much for your attendance, and we will look at the polling results, and my guess is you're going to have more Just Culture coming your way. So many thanks. Have a great month. We'll see you next month.